Hi, everybody. This is Todd, and as you know, we're focusing on severe hypoglycemia and treatment options with our Let's Talk Lows campaign this week. And I've got Dr. Ann Peters here to answer a few quick questions about glucagon use and hypoglycemia with her patients. So, Ann, can you just quickly introduce yourself for our audience?
Sure. I'm Ann Peters. I'm the director of the clinical diabetes programs at the University of Southern California.
Great. And Ann is also a member of the Beyond Type 1 Science Advisory Committee. Really thrilled to have you here. I just want to talk about glucagon use and prescriptions among patients. I've had diabetes for 20 years. I think over those 20 years, I've maybe had 2 or 3 glucagon kits, usually ones that were expired. What percentage of your patients do you think actually have a prescription for glucagon or an active prescription for glucagon?
My patients are all perfect and they all have glucagon at home. No, I'm just kidding. There are 2 things my patients tend to not have at home that worries me is glucagon and ketone test strips. And, you know, people always say, but I don't need it. And the problem is that you don't need it till you need it. And that's why I think every patient, you know, every person with type 1 diabetes should help me as a provider to annually check on everything. So I want, and if I were more organized, and my EMR could do this, but it can't, is that as an annual event, I would check everything. I'd check feet, I would check to be sure the eye exam had been done, I'd check to see that there was a prescription that wasn't expired for glucagon, I'd be sure they had ketone test strips, and if they're on a pump, I'd be sure they had the ability to give injected insulin. And I think that everybody with type 1 should just plan what, you know, like my appointment in the summer, I will do this. And because the more you force me to focus, the more I'll help you. And I tend to do it more by just happenstance. Oh, gee, did you remember? Or, you know, some appointments are longer and shorter depending on the circumstances of the person, but there just needs to be a time every year that that is a bundle. And if that happened, everybody would have what they need, but it doesn't happen that way. And therefore people run out and they don't have their glucagon and they get sick and the family member, you know, doesn't know what to do. And you know, part of it is historically been the training for the glucagon test, the glucagon emergency kits, because I think if you're not medical, to know how to assemble that is actually not easy. And if you were trained on it 10 years ago and suddenly you need to give it to somebody, I think that's really hard to do. So that's why I've been incredibly happy about the fact that we now have easier ways to give glucagon. And I think everybody should get a prescription for the newer glucagon methods. And I try to do that. And one of the problems still is that insurance companies don't always pay for it. But regardless, I think everybody needs a valid, unexpired glucagon administration kit at home, and that their loved ones should be trained on how to deliver it. Even with the Baqsimi, the inhaled nasal glucagon, it's still, they always ask me questions, you know, how do I really do it? And it's really helpful to show somebody, or at least to give them an idea of, you just stick it, boom, and it goes in. But you just want to make it so the questions are asked and answered before it's actually needed.
Awesome. Well, you answered, I think, 3 of my 4 questions just in that response. I did want to ask you about the newer formulations of glucagon and if you thought that would be helpful in getting more people prescriptions for them. And it seems like if one of the barriers was administering glucagon, then certainly maybe people will be more open to carrying these newer forms, but insurance does remain a problem.
Well, and I'm supposed to use non-branded names, but the stable soluble glucagon injector kit is supposed to come out, I think, in July, in the one that's just like an EpiPen. So that I think that both the intranasal form and the injectable form will be really simple to administer, and I'm all for simplicity. Now, as a corollary to all of this, the notion of microdosing glucagon, giving little doses to help prevent not severe lows, but milder lows, has always been something that I've been interested in. And, you know, one of the areas of research I think is going to be in how do we use glucagon, not just for rescuing people from severe hypo, but for helping with post-exercise lows, or helping people not to have to eat for lows. That being said, ever since my patients have had access to some of these smarter systems with the either loop system or the hybrid closed loop systems that you can get from Medtronic or Tandem, the amount of time people are spending low or even having severe lows is really been nicely reduced in my population, just because an automated system can help. So can the continuous glucose monitor. So I'm looking at a world where I hope we don't need to treat severe hypoglycemia, but we're not there yet. But I am an optimist because it's been better in my patient population since we've had continuous glucose monitoring, and then the systems that act upon that to prevent insulin delivery when people are low. So I like that. And I like the notion of adding glucagon into those systems and, low dose glucagon and everything else. But I know I'm going off topic, but that is fascinating to me.
No, yeah, I think that's not too far off topic. I think I could say the brand names. I have both Baqsimi and I do have the Xeris PFS pre-filled syringe already. The automatic HypoPen isn't out, but I think you're right that it is coming this summer. The last question I did want to ask you would just be, when you're telling your patients about glucagon, is there a certain threshold when you tell them like, okay, now would be the time to use it? I think I've both heard guidance that you should be unconscious if someone injects you glucagon, and like, do you tell your patients that they can give themselves self-administer glucagon? And so when would a patient know when to administer glucagon?
Well, so the answer is it's always possible to give glucagon in that odd situation where somebody is too out of it because of a low to ingest much, or they're vomiting or whatever's happening, so they can't get oral carbohydrates in them. And maybe they're alone or whatever, but they're not in a situation where they can give it to themselves, but they're conscious enough of the situation. So I've had people give the inhaled nasal glucagon at that point and do fine. I've also had some patients who really got too sort of sick to their stomach from a low, who've given the injected form, even the old form, but that then can make you more nauseous. But if you can get your sugar up, it's all about having an awareness of, can I ingest an adequate amount of carbohydrate to get myself out of this nosedive? So I don't recommend it for mild lows where people can easily treat them, but I think that there is a role, and it's not in the label, but in my patient population where they've had to give it to themselves. But I always warn people that I think you don't feel very good after getting a big dose of glucagon. And these are big doses. They're not little doses. They're not a dose that's going to make you feel fine. It's going to often make you feel crappy. But it's better to feel crappy than to be on the floor, not conscious from a low. So I think people should and can use it on their own if they're in that setting. But everyone has to think about it, what are my options? And if you're not thinking that clearly because you're fairly low, this can be an option. And again, that's not on the label, but it's how I recommend that people use it. The place, by the way, that I use the most glucagon is in pregnancy. So a lot of my women who are reaching those pregnancy targets of an A1C of less than 6 often are really going low a lot. And that's when I bring the husbands in and I make sure that everybody knows about treating lows. And in those women, we tend to see a lot more lows. The glucagon and the lows don't hurt the baby, but I try to avoid those lows, but those are people who are really skirting lows a lot. So I just want to make sure that those women in particular have glucagon at home and have a significant other who can administer it if needed.
Right. So it's not a specific number so much. It's more situational and has to do with whether or not you can take in carbs and how, I guess, coherent and conscious you are, and then also specific populations.
Right. And if you were in a situation, it just has to do with whether or not you can ingest enough simple carbs. That's it. That's the only, if whatever the circumstances are, if you're somehow away from food, and you're going low and you only have glucagon and you don't have food, it's going to make your liver make glucose and you're going to, have your sugars go up. So I just think it's preferable to not need it and to always have simple carbs to carry and treat lows with, but it may be something people can use. And again, it's always up to your judgment, but it's probably not going to hurt you to take it other than to make your sugar go up and to feel crappy. But, it's better that than certain other circumstances. So like, we send you guys out with your diabetes and say, just manage it. Don't ask these questions. They're too hard. It's up to you. Figure it out. I mean, that's the saddest thing about this whole thing. We're not holding your hand all the time. What can I tell you? But I simply don't want people, by the way, to call me when they're in the middle of a crisis like this. You can, but it's like, don't waste your time calling somebody, just treat it. I mean, honestly, don't debate. It's really have your, and a family member, by the way, may get too scared because you don't wake up faster with any of these glucagons. You wake up at the same rate, and it may be 10 to 15 minutes before the person who, if they're unconscious, becomes conscious. And that 10 to 15 minutes is the longest period of time anyone's ever going to wait because they're scared and their loved one is there on the floor and they're trying to get them to wake up. And so if somebody's scared, it's okay to call 911. And particularly if someone's older and they're afraid that they might have had heart problems or whatever, but these days in particular, we're trying not to call 911. So I think that, like I say, I tell people they can do that. That's when, if you've treated someone, then a patient or a family member, not the patient, but the family member can, reach out to their doctor and say, this is what happened if they need to. But, most of the time, this is something people are going to do all on their own and, reach out if they can and need help, but not till after they've treated it.
Great. Well, thank you so much. I think so. We both are definitely in agreement that everybody with diabetes, type 1, type 2, gestational should have glucagon. And I know earlier we said that not all the insurance companies are covering it. I would still recommend people go to the websites, either Lilly's website for Baqsimi or Xeris's. I was able to get both of them through kind of copay cards, even though my insurance didn't cover it. So I would check and see what those programs are, if they're still in existence, because since they're newer, they are kind of making them available to everybody. And yeah, I guess, is there anything else that you would like to add?
Well, yeah, the only people that, I only give my type 2s on insulin, and usually on multiple daily injections of insulin, because those are the ones who have the most lows. I don't know, most of my patients on basal insulin, I can adjust and they don't have trouble. But certainly patients with type 2 who are on multiple daily insulin injections need this, because if there's a risk for severe hypoglycemia, you obviously need people to have it. I just think, like I said, we need to do this annual assessment, and that's really going to be helpful. And when I'm thinking of going back into the real world of medicine, as opposed to just being home and doing medicine, what I'm thinking of is still doing a lot of telemedicine as long as we get reimbursed for it, because I like it, because I like the access, that it's easier for my patients. It's easier to see people more often. There's a lot of really good things about it, but I still think I need to see people in person once a year to do an exam and everything else. But that's, to me, then would become the natural place where I would do all of the, do you have all the prescriptions you need? And because then if I do it annually, then people will have a year's worth of everything. So my newer model going forward would be to have an annual. And that's, people go for an annual physical. I want an annual diabetes exam that's just this, and that would be for everybody. And then the telemedicine piece will float around that. But I kind of like it because I think it's going to focus me. So that would be my notion of what my practice is going to be going forward. So like I said, think of an annual diabetes event, and that should be when all of this is done. And then everything's going to be fine for you. The thing I hate the most is, always having to worry that someone, they contacted me and they're out of insulin and this and that, and they didn't have this thing, and then 2 months later they don't have that thing. It's really hard for us to keep up with the prescriptions. And if it was all focused once a year, everything was done, then I wouldn't have all this, discordant prescription needing. So to me, I need everything done annually. That would really be nice. It's an ideal world, but this would be part of the annual check.
Well, thank you so much. As always, it's been a pleasure. Dr. Ann Peters from University of Southern California and Beyond Type 1 Science Advisory Committee. I will talk to you again soon.
All right. Take care. Be safe.
You too. Bye.